hello, and thank you for joining us today. My name's Jen Cavallari, and I'm a professor at UConn School of Medicine. I also co-direct the Center for the Promotion of Health in the New England Workplace, or CPH-NEW. And please join me in celebrating CPH-NEW's 20 years of leadership in total worker health. So CPH-NEW is one of 10 centers of excellence in total worker health, and we're funded by the National Institute for Occupational Safety and Health, or NIOSH. So our center has the privilege of being jointly located at both the University of Connecticut at our School of Medicine, as well as the University of Massachusetts at Lowell. We actually host a range of education and networking opportunities. And if you're interested in learning more about CPH-NEW or total worker health, be sure to visit our website or connect with us on LinkedIn. If you're interested in exploring more, including past trends webinars, they're all available on our CPH-NEW YouTube channel. For those of you watching us on YouTube, please like and subscribe so you don't miss future content. So CPH-NEW first launched our Total Worker Health Trends webinar series in March of 2022, and this series is meant to highlight emerging topics in total worker health research and practice. Today's webinar will focus on participatory approaches to workplace stress. Megan Miskovsky will first start us off with an introduction and overview of the Healthy Workplace Participatory Program. Then we have 3 case studies. Serena Rice from UMass Lowell will cover burnout in healthcare workers. Amanda Hiner from the University of Connecticut will cover work overload in educators. And Sara Namazi from Johnson and Wales University will talk about mental health in correctional officers. Let's begin with Megan Miskovsky.
Thanks, Jen. So I'm going to provide just a brief introduction to workplace stress in general and the Healthy Workplace Participatory Program, which was developed by CPH-NEW and was used in each of the following case studies. Now, I'm sure many of you are very familiar with the general concept of workplace stress. A recent Gallup report found that 50% of workers across the United States and Canada reported high levels of daily stress, ranking the highest among the regions surveyed. Just for a frame of reference, at a global level, the average for high stress among workers was about 40%. Workplace stress is defined as the harmful physical and emotional response that occurs when the requirements of a job do not meet the capabilities, resources, or needs of the worker. And this work stress can lead to poor physical health, such as heart disease, digestive issues, and musculoskeletal pain, as well as poor mental health, such as increased risk of depression, anxiety, and burnout. We also know that stress can stem from numerous sources, including the workplace, leadership, and the larger work organization, as well as from the home environment and non-work commitments. And this is important to consider when developing interventions to address stress in the workplace, because the source or the root of the issue provides valuable context for intervention effectiveness. However, workplace interventions don't always take this total worker health approach into consideration. In fact, the vast majority of interventions rely on individual level change and individual level effort, rather than addressing the root cause of stress at its source through the elimination of that stressor or by redesigning the work to reduce it in the first place. This individual level approach results in ineffective Band-Aid solutions that don't work and don't last. And this is where the Healthy Workplace Participatory Program, or the HWPP, comes into play. The HWPP is a research-based, field-tested program designed to support an integrated and participatory approach to worker safety, health, and well-being. And it offers a flexible design, allowing for easy adaptation across diverse workplace settings. The participatory program is made up of both a design team of frontline workers and a steering committee consisting of upper management personnel. These 2 committees are guided by a trained facilitator to work and communicate together to address workplace concerns. And it's important to note that the design of this program and the committee structure is flexible and can be adapted to best fit the unique needs of the organization, as you'll see in later presentations. This multi-team approach fosters leadership commitment while actively engaging and amplifying the voices of workers. The second core element of the HWPP is the Ideas Toolkit. This multi-step process incorporates concepts of continuous improvement and business case planning to produce workable solutions that are in line with resources and strategic goals. The Ideas Intervention Planning process begins with prioritizing health, safety, and well-being concerns with input from the larger work organization. At the next step, the team analyzes the root causes of that concern, and only after that step do they begin to build solutions. Now, these aren't just any solutions. They are developed with the management perspectives in mind. The worker and management teams then collaborate to refine, prioritize, and ultimately implement and evaluate the proposed solutions. One of the core innovations of the HWPP is its explicit focus on employee engagement. It accomplishes this by giving workers specific roles throughout all phases of the program. And why is that important? Well, when employees are actively involved in shaping the program, their attitudes begin to shift. With meaningful engagement, they gain confidence not only in their ability to drive change, but also in their organization's capacity to evolve. Through participating in the program, employees share their firsthand knowledge of the workplace, and this insight enables leadership to better understand the root causes of the safety, health, and well-being challenges those employees are facing, and it provides a clearer path to addressing them effectively. Ultimately, this leads to reductions in accidents, injuries, stress, and poor health outcomes. Now, you can access all of the worksheets and additional resources to support the HWPP online at our website. And with that, I will hand things over to our first case study presenter, Serena Rice.
Megan. Today I'm going to share a case study from a public sector mental health facility in New England. This project used the Healthy Workplace Participatory Program to empower workers and their leaders to co-design interventions aimed at reducing burnout and improving mental health. The workforce here is broad. It's not only nurses, but also mental health workers, social workers, and dietary staff, environmental staff, and campus police. They used the HWPP, guided by the Ideas tool, a structured 7-step problem-solving process. Burnout has been a critical issue in healthcare for years. Before COVID, one in every 3 healthcare workers reported burnout. During the pandemic, this rose to nearly half, with nurses reporting even higher rates. Burnout not only affects worker health, but also contributes to turnover, fatigue, patient safety concerns. To address this, it's to build essential solutions with workers themselves because they know what best drives the stress in their workplaces. So before the pandemic, this hospital that we had worked with, we did some baseline survey data. And what we found was that just over half reported feeling understaffed. Nearly 2/3 said that they were exposed to risky situations. And 62% expressed concern for their own safety. 40% had been threatened, assaulted, or harassed in the prior 6 months. And nearly half reported a sleep deficit, while 30% said that they intended to leave their job within 2 years. These numbers capture the severity of stressors at this facility. Direct care workers were nearly twice as likely to be threatened, assaulted, or harassed compared to non-direct workers. And these are not just one-offs. They were asked how often they experienced these, and 40% said that they have been threatened, assaulted, or harassed in the last 6 months between 1 to 3 times, and 35% said it had happened 4 or more times. So how did we help them approach this? Our approach combined the voices of workers and frontline managers through a design team, which brainstormed and analyzed problems using the ideas tool. Leadership was actively engaged through the steering committee, which ensured that approved solutions could be resourced and implemented. This participatory structure helped ensure buy-in across the organization. So this fishbone here is step one of what Megan was just describing to you. And so the head of their fish is burnout, and some of the sub-issues of that were mandatory overtime, organizational support, retention issues, accountability, that constant threat of violence. This is not exhaustive. This is just a little snapshot of the root causes of their burnout. And reminder, this was all pre-pandemic. Next slide, please. So what did the workers design? The design team identified burnout as their top priority and developed 4 categories of solutions: helping staff actually use their earned time, strengthening staff training, engaging and supporting structures, and preparing staff to manage workplace violence. These categories guided a set of concrete interventions. Some of the interventions included sensory tools to help staff decompress, improved orientation for new employees, a preceptor program to provide mentoring, leadership development training, and clearer policies around taking time off and opportunities for advancement. These were all designed by workers to directly address the root causes of these stressors. But then the world changed and we had a pandemic disruption. So intervention implementation was stalled, burnout increased, and effectiveness evaluation became impossible. Even though some of those activities were approved, many were delayed or interrupted, and still the participatory structures we had built gave workers a way to regroup in the middle of the pandemic. So as they were trying to think about what the new normal would look like as they moved through sort of the middle stages of 2020, they decided to create listening sessions, a worker-led intervention that gave staff space to process what they perceived as their collective trauma of being essential workers during COVID. These sessions encouraged staff to think about what their ideal workplace looks like, and while full analysis of those sessions will be presented another time, they highlight how adaptable and resilient the HWPP process can be. The listening sessions uncovered the root causes like negative workplace culture, poor communication, and workplace violence, all contributors to burnout, which we had seen pre-pandemic in the fishbone I showed you a moment ago. The design team used these insights to keep building interventions that directly targeted stress even beyond pandemic disruption. In 2023, we were able to survey the group again. Some workplace conditions improved slightly since 2018, but major risks remained and intention to leave had actually increased in post-pandemic. So what improved? Adequate staffing. Fewer workers reported understaffing in 2023, down by about 8%. Concerns for personal safety. There were slightly fewer reported folks feeling unsafe. Exposure to dangerous situations, there was a noticeable drop from 65% to 58%. Sleep deficit was nearly unchanged, only 1%, although in the right direction, showing ongoing strain and fatigue. However, intention to leave within 2 years rose significantly, pointing to turnover risks despite some improved conditions, and I suspect that's because they had just come out of working in a pandemic. So the key takeaway is that while safety and staffing indicators show incremental progress, the persistent strain of fatigue and rising intention to leave suggest that burnout pressures are still high and threaten workforce sustainability. Despite the challenges, many of the worker design interventions were approved and are being implemented. The listening sessions expanded engagement, bringing more voices into the process. Workers themselves were trained as facilitators, building long-term capacity for problem solving, and this participatory process has now been expanded to more hospital units. So what did we learn? This case study shows that worker voice is essential to addressing burnout. Participation builds resilience even in the middle of crises. Burnout isn't only about workload, it's tied to culture, communication, respect, and safety. And most importantly, the HWPP model provides a scalable, sustainable structure that organizations can use to continue improving mental health and reducing stress. Now I will turn it over to my colleague, Amanda.
Thank you, Serena. Hi, I'm Amanda Hiner. I'm a PhD student at UConn, and I work on the Total Teacher Health Project. I will be presenting a case study on work overload in educators from a public elementary school in New England. This work was done through the Total Teacher Health Project. It is a multi-phase research and intervention study that focuses on the well-being of teachers in the public education system. As researchers and facilitators for Total Teacher Health, we work with staff and administration from elementary schools in Connecticut to identify the root causes of well-being concerns and develop and implement solutions to address them using the Educator Wellbeing Program. The Educator Wellbeing Program is an adaptation of the HWPP and is an evidence-based participatory program that engages instructional and non-instructional educators in developing and implementing solutions to improve educator well-being. It consists of 3 teams: the educator design team, consisting of educators who represent the school staff, the administrator team, made up by the building administration, and the implementation team, consisting of other educators from the school to provide additional support in implementing solutions. The process uses a structured multi-phase learn, plan, improve approach. The learn stage is when our educator design team identifies workplace strengths and concerns and complete a root causes analysis. The plan stage includes setting and developing goals and activities based on the information gathered in the learn stage. And the improve stage is when implementation occurs with help from the implementation team. The goals of the program are to engage educators and staff in setting priorities and developing solutions, to develop justification and plans for health, safety, and well-being interventions, to improve organizational culture, communication, and collaboration around educator health, safety, and well-being, and to establish a sustainable process for continuous improvement. It's important that we know why this work is so important. First, a Gallup poll from 2022 found that educators have the highest burnout rate of any industry, including nursing. In addition, there is consistently high turnover, leaving over 40,000 unfilled educator positions across the U.S. In fact, about 45% of new teachers leave the field within their first 5 years. Finally, up to 59% of U.S. teachers report experiencing daily stress, but only about 31% of schools offer workplace well-being programs. Many well-being efforts are top-down and one-size-fits-all, but we offer a bottom-up approach and help educators fit the program for their specific needs. Knowing all of this, we found it important to give educators a voice, and that's what we aim to do. The setting for this case study is a public elementary school in New England made up of classroom teachers, interventionists, paraprofessionals, and other staff members. We used the Educator Wellbeing Program made up of the 3 teams I previously mentioned. The educator design team had 7 educators, the administrator team had the principal and vice principal, and the implementation team consisted of 6 other staff members. 3 researchers from the Total Teacher Health team attended each meeting to facilitate the process. About 1 year prior to intervention implementation, we gave a survey to our educators, and this is what we found. 64% felt they had too much work to do, 75% indicated high supervisor support, and 83% indicated high coworker support. 37% had clinically significant anxiety symptoms. 70% indicated that they were asked to do excessive work. 75% said they know what was expected of them, and 38% often thought about quitting their job. In a bit, I'll go over the survey results after implementation has begun so we can compare. We had educators identify strengths and concerns and had them decide on one major health, safety, and well-being concern, and they decided on work overload. We then facilitated a root causes analysis for work overload. You can see our educators' thought process as they went through this. Their concerns ranged from curriculum concerns to lack of time to inaccurate communication. Here are the 4 target areas our educators decided on for change and the changes that they made. For staff training, they decided to create a survey to identify training needs and develop a new training and onboarding checklist to ensure everyone is getting the necessary training. Next is staff rapport. For this, they began after-school team building activities. Next, they wanted to focus on resources. They updated the handbook to include job descriptions, created a template of daily roles to provide role clarity, and created a list of resources for educators to access. For communication, they wanted to ensure accessibility to all available resources by adding hyperlinks. And these are the results of the survey after the EDT put the changes in place for one school year. There was a large decrease from 64% to 39% of educators who felt they had too much work to do, an increase from 75 up to 85% of educators indicating high supervisor support, and an increase from 83 to 89% indicating high coworker support. The first survey had 37% of educators indicating clinically significant anxiety symptoms, and now this is down to 17%. There was a decrease from 70% down to 52% of educators stating that they were asked to do excessive work. Originally, 75% of educators said they know what was expected of them, and now we're up to 89%. And finally, there was a drop from 38% of educators saying they often think about quitting their job to 26%. As we saw on the last slide, based on the survey results, there were many successes, including improved staff rapport, fewer symptoms of anxiety, increased role clarity, and less intention to quit. However, I want to mention some barriers. Ours included not having enough time to work with the educators because of scheduling, a lack of resources, especially staffing for classroom coverage, and the concern of increasing the workload of our educator design team members, while simultaneously working on the major concern of work overload. In conclusion, I want to reiterate what Serena said. Giving employees a voice is incredibly important for meaningful change. The changes that were made would not have happened without our educators. Next, our successes with the Educator Wellbeing Program show that the HWPP is adaptable to specific industries. Finally, both the successes and barriers show us what we need to focus on going forward. It's clear that a participatory program that can be adapted to fit the specific needs of the school and the educators works. But seeing the lack of time, lack of resources, and our concerns about increased work overload on our educators, things we see at all of our schools, we're actively working on our own solutions to adapt and break down these barriers. I will now hand it off to Sara.
Thank you, Amanda. Good afternoon, everybody. Today, I will present on the development and initial findings of a mental health wellness training for the correctional workforce developed using the Healthy Workplace Participatory Program. Correctional employees face many work-related stressors that build over time. Some of these stressors are very unique to their employment, such as repeated exposure to traumatic events. There are chronic workplace stress due to high job demands, organizational challenges related to staffing shortages and mandatory overtime work and shift work, and even stigma around seeking help. In addition, work-related stress often spill over into their personal life, affecting relationships and their overall well-being. And over time, this chronic stress can take a serious toll on correctional staff's mental and physical well-being. Research consistently shows that correctional workers have a significantly shorter life expectancy than the general population, with many factors such as cardiovascular disease, hypertension, suicide as contributing factors to this shortened life expectancy. There are very limited workplace policies that protect this working population, very limited mental health support on and off the job. And correctional worker health, unfortunately, is often overlooked, an overlooked topic in discussion of criminal justice reform. So in 2019, the high-tech program, or Health Improvement Through Employee Control, partnered with the American Federation of State, County, and Municipal Employees, or AFSCME, Local 391, which is a major labor union representing public service workers, including many correctional officers. And this partnership led to the establishment of the Local 391 design team. I serve as an advisor to this regional team alongside my co-advisor, Stan Quinto Suddeth, who is a retired correctional officer. And together we were able to organize a design team of 12 members who meet bi-weekly at the Local 391 Union Hall in Enfield, Connecticut. And our team members represent a range of job roles, including kitchen staff and maintenance staff, counselors, and frontline correctional officers working in facilities that are located in the northern part of Connecticut. Our goal since day one as a design team has always been to promote awareness of the impact that the physical work environment and the organizational culture within DOC has on staff safety, health, and well-being. And the focus of our work has really been to promote health equity within this working population and to identify risk factors that are unique to correctional worker safety, health, and well-being, and to work with subject matter experts to identify evidence-based resources and to design and implement and evaluate interventions for correctional workers. And as a design team, we use the Healthy Workplace Participatory Program to design workplace interventions around health, safety, and well-being for correctional workers. When we first organized as a team, we had our members go through an orientation to the HWPP process, which really helped us understand as a team the participatory approach and our role in shaping workplace interventions. We then moved on to getting familiar with and getting oriented to the IDEAS tool, which stands for the Intervention Design and Analysis Scorecard. And we used that tool and got oriented to how we can systematically identify problems within an organization, brainstorm solutions, and prioritize interventions. And the high-tech program will provide ongoing orientation and training as we get new members joining our design team. And early on in the process, we also contextualized the CPH-NEW all-employee survey to get some baseline data from correctional staff on safety concerns, some baseline health data, and about well-being concerns on the job and outside of their job. And so we adapted this survey to create what we call the Design Team Mental Health Intervention Survey. Again, allowing us to capture staff perspective and using that data really to ground our interventions in the realities of correctional work. We administered our baseline survey in 2019 at 3 correctional facilities, and we got around 350 participants. And we found a lot of alarming results that highlights a significant need related to staff health, safety, and well-being. So more than 50% of correctional staff reported moderate to extreme stress at work. About 43% scored at or above the clinical threshold for depression. A little over a third scored at or above the threshold for PTSD. We asked questions about whether, how would you rate your mental health before joining corrections and after, and we saw a decline in that rating. About 74% reported that their job does not provide them with any mental health resources, particularly training or services. Majority indicated that, following a critical incident, there's no policy in place that allows for decompression time. And more than a third expressed interest in seeking mental health care, which was very promising to us. So we use these findings along with conducting a root cause analysis using the IDEAS tool to guide the development of practical, actionable solutions, making sure that we are addressing system-level change and also individual support needs. So at the systems level, we designed solutions that focused on more, addressing administrative tasks that cause stress for correctional workers, particularly around report writing and enhancing that process for correctional workers. We also implemented and are currently working on expanding a peer support program. But at the individual level, we focused on designing a mental health training for staff. So I'm going to talk a little bit more about our mental health training next, but I'm happy to address any questions that you may have about the other interventions. So for 2 years, we collaborated with subject matter experts, including psychologists in training at University of Connecticut STORS, to develop evidence-based educational content around mental health. We worked on stress management techniques, and related information were adapted from the Kevin Gilmartin's book on emotional survival for law enforcement. We also incorporated theoretical frameworks in our training, such as the multipath model of substance use disorder, to illustrate the biological, sociocultural, psychological, and social dimensions of substance misuse. And so we came up with a 2-hour training that is broken up into 3 parts. The first part focuses on sort of building awareness around correctional work life and how that impacts mental health, in addition to presenting, the current evidence around this specific topic. And then the second part focused on helping staff identify signs and symptoms that cause stress within themselves, but also their peers. We went through stress management techniques and strategies with staff, and then also going through techniques around signs and symptoms of alcohol and substance misuse. And the final part of the presentation focused on identifying resources available to correctional workers, both on and off the job. So after we developed the training, we pilot tested it in 2023 with 132 correctional staff. The training was held inside correctional facilities, and we were given 2 hours. The training was delivered by correctional staff. Again, on the UConn end, we provided our, content matter expertise, but the staff themselves delivered the training. Staff were relieved from their post to attend the training, and once we completed the training, we administered a post-training survey. And then, we took the survey responses and content analyzed them and conducted a thematic analysis. So the post-training survey asked 2 questions. The first question was, what are the most important things you've learned during this training? And we found that most staff indicated that they had learned stress relief and coping techniques, followed by self-care, self-investment techniques, and personal health awareness. With regards to our first question on the survey, what are the 3 most important things you've learned? With regards to stress relief and coping, staff members indicated that that they took away the importance of finding hobbies, making more time to de-escalate. Another staff member said the importance of breathing and taking a minute to refocus or calm down. Another staff member said ways to cope with stress and the importance of having healthy habits and hobbies. With regards to agency, self-investment, a staff indicated that they've learned how to manage stress, the importance of exercise, and healthy eating. Another staff said getting proper sleep is important, and having positive outlets outside of the job to deal with our line of work. And with regards to personal health awareness, staff indicated that they learned about what stress can do to their body, how much my job affects my real life, the signs and symptoms of clinical depression, anxiety, and PTSD, and the small changes that can make a big difference. For the second question, we asked, to what extent do you expect this training will make a difference in the way that you view on-the-job stress? And most indicated that the training was effective in changing their perspectives on job stress, and majority also agreed that the material covered was appropriate. So, and relatable, that the right amount of content with focused instruction was provided, and that they got valuable information and reminders about how their job impacts them. But we also got some feedback on ways that we can improve the training. Specifically, staff wanted more hands-on learning about coping, and they wanted us to include or create a training for family members, which we ended up doing also. And they wanted us to repeat the training for reinforced learning, and more training on how to identify stressors in themselves and colleagues. To wrap things up, we're keeping this training going by expanding our reach to other facilities. We have been getting a tremendous amount of support from staff and lots of management buy-in. At the heart of all this is that this training was created by staff for staff, staying true to the core principles of participatory action research. We've noticed an increased awareness and reduced stigma around mental health. And of course, there are some barriers that we also face related to time constraints, and there still is a bit of, that lingering cultural stigma around mental health. We saw some staff turnover and some other sustainability challenges related to time and communication. With that being said, I'll turn the presentation over to Jen. Thank you.
Thank you to each of our speakers. It's so interesting to hear how when workers are put in the driver's seat, they are really able to contextualize and create solutions that work for them and their environment. Please be sure to complete the survey evaluation if you would like a certificate of attendance. At the end of that survey, you can create one after completing it. And please be sure to like and follow our YouTube channel to be up to date on all the CPH-NEW presentations and offerings. Thank you all. Be well.